Hello and welcome to the video. In this video, we are going to talk about varicella zoster viral infections. Now, the infections caused by the varicella zoster virus, they occur in two forms. First is varicella or chickenpox, which is also known as the primary disease, and second is herpes zoster or shingles, which is also known as secondary manifestation of varicella zoster viral infections. Now, let us understand the difference between the two. First is primary disease or the varicella or chickenpox disease. These occurs in the individuals who are lacking antibodies or who are seronegative, that is the initial infection or the first time infection in an individual by varicella zoster virus, it is termed as varicella or chickenpox. Now, in secondary disease, when subsequent or reactivated manifestation of herpes zoster virus is seen, it is known as shingles. Now, varicella zoster virus shares structural similarities with herpes simplex virus, such as the DNA core, a protein capsid, and a lipid envelope is also present in varicella zoster virus. These similarities aid in understanding the mechanism of infection and potential treatment options for varicella zoster viral infections. Microscopically, there is remarkable resemblance between varicella zoster virus and herpes simplex virus. Both the infections typically are present in cutaneous or mucosal forms as vesiculo-ulcerative eruptions. While there are striking similarities between the varicella zoster viral infections and herpes zoster viral infections, there are certain signs and symptoms that appear to be distinct in each infection. Now, understanding these unique characteristic differences are important for us for accurate diagnosis and effective management in the cases of varicella zoster viral infections. Now, we will talk about pathogenesis or how the virus infects a host. Now, varicella is primarily transmitted through the direct contact with the contaminated droplets from the skin or by inhaling the aerosolized virus particles. Now, these virus particles, they are highly contagious and they spread from person to person very easily. Now, after the virus is transmitted into the new host, the incubation period for varicella zoster virus is approximately of 2 weeks. During this 2 weeks, the virus multiplies within the macrophages. Now, due to this multiplication within the macrophages, it will lead to viremia, that is presence of virus in the blood. And now the virus is in the blood, and from the blood, this virus will disseminate into skin and other organs of the body. Now, following this dissemination, the body's immune response gets activated, which includes cell-mediated immune response and specific humoral-mediated immune response, including the production of non-specific interferons, which are activated in response to the virus. Now, imagine it like this. The virus is now proliferating in the body. So, overt clinical symptoms and manifestations in most of the individuals will be seen as the virus surpasses the body's defenses, leading to systemic signs and symptoms. Now, after the onset of clinical disease, in case of healthy individuals, the immune response, it eventually limits and halts the viral replication, allowing for the recovery within 2 to 3 weeks from the onset of symptoms. After this recovery, there will be a latent infection present in the body. During the course of the disease, the varicella zoster virus may travel along the sensory nerves to the sensory ganglia, where it can establish a latent infection in an undetectable form. The later state can lead to reactivation of virus later in life when the immune system gets compromised, resulting in the herpes zoster infection, or we can call it as shingles, which is also known as secondary infection of varicella zoster virus. Reactivation of the latent varicella zoster virus leading to herpes zoster infection is uncommon, but it typically occurs in individuals with a decline in cell-mediated immune response, particularly in elderly patients or those patients who are experiencing immunosuppression due to the conditions such as malignancy, especially lymphomas and leukemias, where the body's immunity decline, drug therapy or HIV infection therapy. Additionally, radiation, spinal cord surgery, local trauma can be some triggers which may lead to reactivation of secondary lesions of varicella zoster viral infections. But there is a difference in secondary infection from the primary infection. The lesions, they cease to be infectious once the lesions have reepithelized. Means there is a phenomena that is known as reepithelization, which occurs in secondary lesions. Due to this epithelization of the vesicles, the infection is no longer contagious. Prodromal symptoms include pain or abnormal sensations, which is also known as paresthesia, which precede in development of vesicular skin eruptions, typically occurring on the sensory nerve of a dermatome. The vesicles, they progress to become pustular and eventually they ulcerate. The disease, it typically lasts for 2 to 3 weeks. Following the acute phase of the disease, approximately 15% of the patients, they may experience post-herpetic neuralgia that is characterized by persistent pain that can last for several months. Along with this pain, some individuals may also notice cutaneous hyperpigmentation as a consequence of infection from the varicella zoster virus. Now let us talk about clinical developments or clinical features. For varicella, an effective attenuated live vaccine was developed in mid-1970s by Dr. Michiaki Takahashi of Osaka, Japan, after his son developed chickenpox. Now, with widespread vaccination presently available in developed countries, varicella is uncommon. Historically, varicella was very common disease, affecting large majority of the population before the introduction of vaccines. Now, as we said, that varicella typically manifests in childhood with symptoms including fever, chills, malaise, that is bodily discomfort, and headache. All these symptoms are accompanied by rash, primarily affecting the pathway of the sensory nerve, which mostly involves trunk, head and neck. The rash quickly progresses into vascular eruptions. These vesicles, they become pustules, and these pustules finally break open to form ulcers. Now, successive crops of new lesions or successive clusters of new lesions, they appear in the body owing to repetitive waves of viremia, that is the infection of virus in multiple stages. This causes the presence at any one time of all the lesions at all the stages of development. The infection is self-limiting and lasts for several weeks. Oral mucous membranes may be involved in primary disease and usually demonstrate multiple shallow ulcers that are preceded by vanishing vesicles. Now, due to intense itching of the skin lesions, the secondary bacterial infections are not uncommon, which may lead to healing with the scar formation. Now, complications such as pneumonia, encephalitis, and inflammation of other organs are rare, but they are possible, especially in the small percentage cases where the person is immunosuppressed. Varicella can have more severe and prolonged effects in older adults and immunocompromised patients, leading to increased likelihood of the complications caused by the reactivated virus. If the varicella infection is acquired during pregnancy, it may result in fetal abnormalities as well. Now, herpes zoster or shingles, it predominantly affects older adults and individuals who are immunocompromised. The incidence of herpes zoster, it increases with increasing age, with approximately 10 cases reported per 1 lakh patients observed by the age of 80. The sensory nerves of trunk, head and neck most commonly are affected by herpes zoster, which involves various branches of the trigeminal nerve that can lead to unilateral oral or facial or ocular presentation. That means the herpes zoster, it will not cross the midline of the body. Facial and auditory nerve involvement can result in Ramsay-Hunt syndrome, which is characterized by facial paralysis along with vesicles on the external ear of the same side. These vesicles may also lead to symptoms such as tinnitus, deafness, and vertigo. Tinnitus, I hope you all know, that is a perception of noise such as ringing or beating noise. The sound of in the ears when nothing is around. Now, herpes zoster typically begins with several days of prodromal symptoms, such as several days of pain or several days of abnormal sensations. Now, following the prodromal phase, a well-defined unilateral maculopapular rash, it emerges in the affected dermatome. Along with this rash, occasionally systemic symptoms can also be seen. The rash rapidly evolves from becoming vesicular to pustular and then finally lead to formation of ulcer. Now, remission usually occurs within several weeks, marking the end of the acute phase of infection. Finally, the complications of the herpes zoster can include secondary infection of the ulcers, post-herpetic neuralgia, which may be resistant to painkillers. Motor paralysis can occur. Ocular inflammation can occur. Ocular inflammation particularly occurs when the ophthalmic division of the trigeminal nerve, it gets affected by the herpes zoster virus. Now we need to differentiate these varicella zoster viral infections, so we will talk about the differential diagnosis. Varicella is diagnosed based upon the patient's history. Basically, we will ask the patient history of exposure to the virus, and we will see the type and distribution of the lesion. Similarities may exist with the other primarily viral infections such as primary herpes virus infection and hand-foot-mouth disease, that is HFM disease. Herpes zoster is often mistaken for recurrent herpes simplex virus infection and may present similarity on the clinical examination. However, certain features such as long duration, more intense prodromal symptoms, unilateral distribution with abrupt end at midline, and the presence of post-herpetic neuralgia are suggestive of herpes zoster. So these points you must remember for giving a final diagnosis as herpes zoster. In cases where the diagnosis is uncertain, definitive tests such as virus antigen typing, DNA hybridization methods and immunochemistry can be employed to confirm the presence of varicella zoster virus. The morphology of varicella zoster virus and the inflammatory response to its presence in both the varicella and herpes zoster are essentially the same. Microscopically, the virus-infected epithelial cells, they also show homogeneous nuclei representing viral products with the margination of the chromatin along the nuclear membrane, which is also similar to herpes simplex virus. Multinucleated infected cells are also typical. Acantholytic vesicles like herpes simplex virus infection are also present, which eventually break down to form ulcers. But here, in uncomplicated cases, the epithelium regenerates from the ulcer margins with little or no scar. Now finally, we will talk about the treatment approaches. The varicella or the primary infection will have different treatment approach, and the herpes zoster or shingles will have different treatment approach. First, we will talk about the treatment of varicella. Supportive therapy is typically sufficient for healthy individuals with varicella. For example, antipyretics against fever and analgesics against the pain. Immunocompromised patients may require more aggressive treatment, including antiviral therapies, systemically administered drugs effective against herpes simplex virus such as acyclovir, vidarabane and interferons, and the use of corticosteroids during the acute phase of the illness has not been proven to reduce the incidence or has not been proven to reduce the severity of the post-herpetic neuralgia. A highly effective method to save a person from the primary infection of the varicella zoster virus is vaccination, where a highly effective vaccine, live attenuated vaccine, is given to the person. It has been available since 1995 and is routinely administered in the children. Widespread vaccination has also led to significant reduction in the varicella cases, along with significant reduction in hospitalization, mortality, and the disease burden of the varicella. Now next is treatment for secondary infection or herpes zoster or shingles infection. Patients with intact immune response and herpes zoster are typically treated empirically. Oral acyclovir at high doses, that is 800 mg 3 times a day for 7 to 10 days is given. It has been shown to shorten the disease course and reduce the post-herpetic pain or post-herpetic neuralgia. Analgesics, they provide limited relief from pain, and topical antiviral drugs may offer some benefit if applied in early stages. This is all for the varicella zoster infection video. If you learned something new, please give a thumbs up and thank you for watching.